Hi everyone, thanks for joining us today for Ask the Mayo Mom on Facebook Live. I'm Dr. Angela Mattke, a pediatrician and mom at the Mayo Clinic Children's Center in Rochester, Minnesota. Each month I host a Facebook Live session about pediatric health topics, and today I have Dr. Joseph Dearani here as a guest. Dr. Dearani is a well-respected and world-renowned pediatric cardiothoracic surgeon. He's also the department chair of cardiothoracic surgery at Mayo Clinic. Today we'll be discussing and answering questions about congenital heart disease and cardiac surgery, often required to repair the heart and improve heart function. Today we've had many questions already come in on the Mayo Clinic Connect website, so thanks everyone for their engagement already. We'll try to get to as many questions as we can today. So hi Dr. Dearani, thanks for joining us today.
Hi Dr. Mattke, it's great to be here.
Great. Can you start by telling us a little bit about your specific interests in cardiothoracic surgery and pediatric related?
So my specific interest is in cardiac surgery with a focus in congenital heart disease. Mm-hmm. And the interesting thing about our practice at Mayo is it's congenital heart disease that spans the whole spectrum of age. Mm-hmm. And what many people don't know or appreciate is there are more adults with congenital heart disease than there are children now. And that's because of all the great successes and advances with infant and pediatric, heart procedures that get them into the adult years.
Right.
And so that's really my main focus, and try to apply minimally invasive approaches whenever it's feasible. Of course, cosmesis is a very important thing for children, and of course when they go on to be adults.
Absolutely. Well, let's start by explaining what congenital heart disease is, I think, so we can build a foundation to go on to talk about more complex congenital heart disease lesions. So congenital heart disease is a basket term that we give all children that are born with a heart defect, meaning their heart is abnormally structured, or the blood flows in places where it typically wouldn't. Often congenital heart disease is divided into two different areas, so cyanotic and non-cyanotic heart disease. Can you explain to us what the difference is and maybe why it would matter in timing for surgery of a child?
So as you alluded to, congenital heart disease refers to structural heart defects, and the structural heart defects could be anything from holes in the heart to blood vessels abnormally entering the heart or abnormally leaving the heart. And it could be valve-related problems. And depending upon what problem it is or what combination of problems, you can end up with cyanotic, which means blue. It means the child is blue. And a child with a structural heart defect that results in blueness is due to one of two things. It's either due to not enough blood flow getting to the lungs, which makes them blue, or it's a situation where all the blood is mixing in the heart. Normally the heart is separated, and we have blue blood on one side and we have bright red blood on the other side that's full of oxygen. And the defect results in all of this blood being mixed together, so the blue blood is a little redder than it's supposed to be, and the red blood is a little bit bluer, results in the child being blue. Most cyanotic, blue defects require correction early on in life. Mostly because they're symptomatic, and also for brain development. I mean, we've learned with many lesions that when children have low oxygen levels in their blood, the brain doesn't develop normally. And of course, the greater the blueness, the more concerning it would be. So now the focus for most lesions, the vast majority of lesions, is to fix things in the first year of life, sometimes in the first month, sometimes in the first week. And so the focus now is on early correction so that we get around all of the long-term sequela when you can get things back to what they should have been like from the beginning.
So there are so many different types of congenital heart diseases, and one specific type of congenital heart disease, whether it be like an tetralogy of Fallot or an ASD, in one child is not the same in another child. They can be very different in every single child. Are there certain types of congenital heart disease lesions that may never require surgery or may be able to do less invasive approaches?
Sure. So that's a great question. So actually, probably by definition, the most common congenital heart defect is the bicuspid aortic valve, which may not require anything, but about 2% of the population has a bicuspid aortic valve. And at some point in time in life, probably 2/3 of those will develop some degree of narrowing or leakage that may require attention. So if you take that as the most common lesion, the vast majority probably are not going to need anything, at least for a long period of time. But we don't really think of that when we think of congenital heart defects the way that we were just describing. We
Right.
think of these other sort of the more complicated ones. The ASD is a very common one. And actually now there are percutaneous, methods to close it. It depends on the anatomy of the ASD, which is a hole between the receiving chambers. Depends how big it is. Depends where exactly it's positioned in terms of whether it's in close proximity to an important structure that cannot be compromised by the device.
Right.
But many of the other ones will require surgery, and we try to correct it. We try to get it back to the way it was supposed to be from the beginning as often as possible.
Okay, thanks. Well, you talked about kind of bicuspid aortic valve being one of the most common congenital type of heart disease, but you also operate and see very rare types of them, and one of them is called Ebstein's anomaly. And you happen to have a very specific interest and expertise in this area. Can you tell us a little bit what Ebstein's anomaly is?
So Ebstein's anomaly is a very rare anomaly that affects the right ventricle. It's actually a myopathy of the right ventricle. A lot of the attention focuses on the tricuspid valve because the tricuspid valve develops from the ventricle. And so because the ventricle's not normal, the valve does not develop normally. The thing that's really unique about Ebstein's anomaly, you alluded a little bit to some of the other anomalies, tetralogy of Fallot, ventricular septal defect, atrial septal defect. Actually, to be fair, the anatomy of those defects is relatively reproducible from patient to patient.
Okay.
And there are subtle differences, but the general anatomic abnormalities are pretty similar from one to the other.
Okay.
If you take an anomaly like Ebstein's anomaly, it's actually the congenital heart anomaly that has the widest variation in anatomic variability, and it has the widest variability in clinical presentation. So you could have a symptomatic newborn baby that needs to be operated on in the first 24 or 48 hours of life, and you could have one that's mild enough that it trickles through the adult years, and I think the oldest we've operated on now is 80.
Wow.
And then you have everything in between. Now, obviously, most of them come to surgery in the childhood years,
Okay.
And there are some that can remain in pretty well compensated and not need surgery till the adult years. But the attention focuses mostly on the valve. There are other things we do at the time of surgery. We make the ventricle smaller. We make the atrium smaller. We close holes in the heart. We repair the valve, and the operation differs from patient to patient because the anatomy differs from patient to patient.
Right.
But we've got a long-standing history of dealing with it here, and I was just fortunate to sort of have fallen into a situation where there was already a track record, and I just got groomed and mentored and just sort of carried on the legacy.
Absolutely. We have a question from Joanne NZ. So she describes her 14-month-old daughter who has a really complex combination of congenital heart disease. So she has Ebstein's anomaly and describes it as trivial tricuspid regurgitation. A couple other congenital anomalies, including bicuspid aortic valve, a small aortic annulus, severe subaortic nearing, and a subaortic membrane, abnormal mitral valve with mitral regurg, a small ASD, and a VSD. So she has a lot of abnormalities with her heart. And she asks, what factors would you determine when or if surgery should be performed on a patient with Ebstein's anomaly?
So the first is how the child is doing. And if the child is not doing well, and in a child this young, not doing well would be not gaining weight. It would be heavy breathing is probably the most common sign of heart failure in a child. So if the child is having problems from a clinical standpoint, that usually implies that something needs to be done, an intervention needs to be done. And whether the intervention is surgery or not, that needs to be determined based on the magnitude of each of those abnormalities.
Right.
The other, because many of these children, despite having a list of lesions like that, many children can be quite well compensated, and the decision to do surgery is based more on what the echocardiogram looks like and what's going on with the heart.
Okay.
If we see the heart getting enlarged, if we see the function going down, if we see a valve leaking more because of one of the defects that you described, then that may drive the intervention in an effort to avoid progressive deterioration of heart function, something like that. This example brings out and highlights the importance of being evaluated by a multidisciplinary team, because making sure that the imaging and the diagnoses are accurate and you know exactly what the magnitude of each is. a very astute, cardiologist or pediatrician that can really put together how the child is doing clinically. What the experience of your surgical staff is like in terms of do they have a good track record with this combination of problems? And if they do, that might be a vote for earlier intervention. Whereas if they don't, then it maybe we wait a little bit. Maybe it needs to be referred to another institution and so on. So it really requires a multidisciplinary approach to make sure that the analysis of the problem is really being done accurately.
Absolutely. And even the echocardiogram, or the technician who's doing the echocardiograms, we were talking earlier about how important it is to have good people from imaging, as well as the rest of the multidisciplinary team that you mentioned.
Imaging, from a surgeon's standpoint, imaging is changing surgery, not just for us, but very much for us, because these defects are complicated. I usually mention this story. The first 50 years of cardiac surgery were marked by new operations being done to address complicated lesions. I believe the next 50 years, I think the ability for surgeons to come up with new operations is gradually plateauing. There will be a new this and a new that from time to time, not like back in the 60s and 70s. I think the next 50 years of cardiac surgery are going to be marked by the ability of the surgeon to perform an operation close to perfection because of the imaging that is available to them in advance. We actually have situations now where you can print out three-dimensional models. You actually, if you wanted to, you could practice doing the operation on the model before you even walk into the operating room. So the imaging is a wonderful diagnostic tool to confirm accuracy, and it's a wonderful educational tool to sort of pass on the trade.
Yeah, the 3D printing has really revolutionized surgical preparation. Yeah, absolutely. So when you were deciding, once you've decided you want to do an Epstein's repair, you're going in to do surgery on this child, what are the options for surgical repair? Are there different surgeries that are done?
Well, the ultimate goal is to repair the tricuspid valve. That's the ultimate goal. And there have been more repairs described for this anomaly than anything else in surgery. And that is because of this anatomic variability. Everyone is a little different. Every time you open up the heart, what you see is a little bit different, so what you do is a little bit different. We try to establish some ground rules and some general principles that we adhere to that are constant from operation to operation. That is keeping it as structured as possible and minimizing the amount of improvisation that the surgeon has to do, because that is more vulnerable to mistakes and errors. So I think that this is really that's where the focus is. Then we close holes, we trim the heart, we make it smaller, we any other sort of blemishes we try to make the best of. But most of the focus is on the valve, the tricuspid valve in this case.
And trying to repair the valve naturally without having to do any type of replacement is your ultimate goal?
Absolutely.
Absolutely.
That is a general principle for all valve-related problems. There are some that lend itself very favorably to repair, and there are some that you really can't repair. They just need to be replaced. But the tricuspid valve and the mitral valve, those two valves for sure are valves where the surgical focus is on valve preservation and avoidance of valve replacement.
Okay, great. We have another question. This one is from Dorothy, and she says her son has Epstein's, an ASD PDA pulmonary atresia with severe valve stenosis. She had a question for valve replacement you were talking about, and you alluded to the goal is to try and always preserve the valves.
Yeah. So what she's describing though, you said Epstein's with pulmonary atresia. So pulmonary atresia means that the pulmonary valve is not developed. So in that child, now we'd have to look at the imaging. The pulmonary valve would need to be replaced because it's not there. The tricuspid valve you'd want to preserve. So there are, that would be one strategy for that anomaly, is to replace the pulmonary valve with a prosthetic valve, since it's not there. So there's no way that you can preserve it because it's completely absent. That's what the anomaly is. But then repair the tricuspid valve. So that in this particular situation, one valve would be repaired, one valve would be replaced.
Thanks. So you have mentioned that Epstein's anomaly is something that Mayo Clinic has a breadth of experience in for over 50 years of repairing. I imagine that you guys have some ongoing active research studies. Can you share with us some of the trials that you guys are currently working on?
So there are two general categories of research we're doing with Epstein's. Of course, we feel a responsibility to the medical and surgical community to sort of share the lessons learned. So
Absolutely.
there's a lot of retrospective research from a diagnostic standpoint, what we've learned about echo, what are the views, what are the pearls and pitfalls from echo or CT or MRI to make sure that you really pin down the diagnosis. You've outlined all of the anatomic details that the surgeon or whoever's going to be involved wants to know. And then we look at the results of the outcomes of our patients. So this is sort of the category of retrospective research, outcomes research, looking at how we've done, what our track record is. The other type of research is more prospective research, and we do have a stem cell study that we are starting, toward the end of this year. I mean, it's open now, where at the time of surgery, we are injecting stem cells from that patient that was procured the day before and then prepared in our hematology lab, and then re-injected into the weakened heart muscle at the time of their Epstein operation. And the premise behind it is, if you recall in the beginning when we started, Epstein's anomaly is a myopathy of the right ventricle. So the right ventricle is not normal, and there's variation with that. You have right ventricles that can be really pretty good. You can have right ventricles that can be very, very poor. And the strength of the muscle is an important feature for quality of life as well as valve performance. And so if the stem cell research really turns out to be, we have already done this in some patients, not with Epstein's anomaly, but other lesions.
Okay.
And the early results have been very encouraging. I mean, we
Great.
see ejection fractions and ventricular performance get better.
Great.
So this could be a life-changing thing for a lesion like Epstein's anomaly, just being an example of one
Right.
of many, where at the time of the operation where you're fixing valves and closing holes, you're also giving back cells that have the ability to regenerate into muscle that is more functional, that could perform better than what they have. And I think that this is really this could be one of this could be the next great milestone in medicine.
Absolutely.
If stem cell therapy works out, not just for cardiac, but for a whole host of specialties.
Absolutely. That you answered a question that Christina MM had sent in about being able to use stem cell transplants for heart valve replacements. And your trial is going to be actively recruiting pediatric patients?
Right now, the initial trial is a safety trial, and it's in pediatric patients only.
Great. She had another question about, is Mayo actively collecting data on children in regards to surgical outcomes? You answered that question. But she also has an interesting point, talking about neurodevelopmental delays and reinnervation rates and successes. Is that something that you guys have been studying as well?
So in our surgical meetings and medical meetings, neurodevelopment in the setting of cardiac disease is kind of a buzzword now at the meetings. And there is a lot of research going on in terms of when we're doing operation on children, particularly babies. Are there precautionary measures that we can do to try to optimize preservation of brain development? And that's ongoing everywhere. There are some institutions that have committed enormous resources to try to really focus on that. And there's a lot of general things that all practitioners do, across all practices, in institutions that are relatively straightforward and are sort of best practices, so to speak. Whether there are things beyond that is what we're learning, whether there's any medical therapy, the timing of surgery, as we talked about. I mean, we're doing surgery earlier and earlier and earlier and earlier, so that we're really optimizing the possibility for normal brain development. But some of these children require repeated procedures, general anesthetics, and they're on perhaps sometimes many medicines. All of these things can contribute and can be potentially detrimental. But it is a focus, and physicians are generally preoccupied with really trying to make sure that that's okay.
Absolutely, absolutely. That's where the multidisciplinary team comes in, is so important. And if someone really trying to coordinate, if there's multiple surgeries that are going to be going on that day, making sure the child's only going to have one anesthesia exposure.
Yeah, but even one of the things that we didn't talk about, and while surgery has gotten really, really good in the last 50 years,
Right.
there are very few things that we fix that are permanent.
Mm-hmm.
We are palliators in many ways. We design operations with the intent that hopefully it will be the only one that this child or that child needs. But we know for many of these lesions that they will be back. They'll be back because of a residual lesion. They'll be back because of a new lesion, most of which it turns out we've learned is valve related. I mean, 75% of reoperations that occur over the course of a lifetime with a congenital heart defect, 75% of them are valve related problems. And so there's a lot of research in valve technology, you know, increasing the durability of valves, by growing biological valves. I mean, this is where a lot of the focus is. And so when we are counseling parents and we are designing operations, we're designing operations that we want to work well now and can be performed at low risk, but we also want to get as much mileage out of that operation as possible. This is where the collaboration with the interventional cardiologists come in, because when a valve wears out, it may be feasible to add on an interventional procedure to delay another operation. And if you're able to do that enough over the course of a lifetime, you might be able to have a situation where patients have 2 or 3 operations over the course of 70 years, as opposed to 5 or 6. And this is something that's going to be great for patients, and it's going to be great for their family members and loved ones, which is stressful for them when they're in and out of the hospital all the time having repeated procedures.
Speaking of family members and loved ones, is there any specific advice that you would give a family who's had a child who's been recently diagnosed with congenital heart disease?
Yeah, the first thing that I would do is I would encourage them to educate themselves as much as they can about the lesion. What we're doing right now is a wonderful example of how that can be done. Social media and the internet is immediate access to all sorts of information, some of which is really tailored and focused toward the lay person, so not fancy medical terminology. So that would be the first thing, is to try to educate themselves, learn about the doctors that are going to be taking care of them. When interventions need to be recommended, make sure that the operator is experienced. Ask them about track record. Ask them about other infrastructure. I mean, a surgeon is only as good as they can be. They're sort of at the whim of everybody else around them. So a perfectly, performed operation, can go bad if, the ICU care is not good, or if the wrong diagnosis was made in the beginning. So you can see the importance of a collaborative, interdisciplinary approach to problems. The next thing is that the outlook should be very positive and hopeful for the overwhelming majority of lesions. I mean, the vast majority of congenital heart defects can be fixed with a wonderful quality of life, with a lot to look forward to. There are some that are challenging, and the practitioners need to point that out, and they need to walk the families through what the expectations are. But those lesions are the exception, not the rule. And then I think the other thing would be to connect with support groups, and the internet is another wonderful resource for support groups, because the medical community cannot disclose and exchange names of patients so that people can learn more, because we violate confidentiality regulations. But there are many social networks, in social media, support groups where there are talk boards, and then patients can just connect themselves. And this networking, I have found, is wonderful reassurance for patients and families. Because they'll talk to somebody who Dr. So-and-so in some institution took care of. They'll tell you what was good about it. They'll tell you what maybe was not so good about it. And so it's a great way to connect and learn. And I would encourage all families to try to do that as much as possible. So knowing about their practitioners, knowing skill sets, knowing what their outcome rates are, and connecting with others to learn what their experience has been like, and educate themselves. They cannot learn enough. This will be a lifelong process. Even if an operation goes well when they're 1 year old, there's going to be some surveillance by the medical community. There will be repeated visits. There will be repeated imaging studies, and they want to become really quite familiar with the terminology so that they really know. they need to take ownership of their problem, so that when they get through the adolescent years, they're going to college, there needs to be an orderly transfer from pediatric practitioners to adult practitioners, and parents, when they're young, need to take ownership and be accountable, and then when the patient gets old enough that they can then start assuming more and more responsibility. That is what patients need to know.
Absolutely. You have been very active, Dr. Dearani, on social media. So you have several Facebook pages, and from those Facebook pages, especially the Epstein's, there's been multiple support groups that have kind of branched out from those. Can you share a little bit about your activities on social media in case people want to find you?
Sure. So, well, I have my own personal Facebook page, which is completely non-work related. It's for friends and family. You may not even be able to tell that I'm a physician looking at it. I don't friend patients on my personal Facebook page, just because Mayo does not want us to do it. It creates a conflict, and I don't want there to be a situation where I'm friends with one patient but not another. So if I get requests, and I don't do it. It's just it's not. But with that aside, we have created a number of Facebook pages at Mayo Clinic for various anomalies. And what we've done is we've sort of cobbled all of the information together that would be appropriate for a patient. So there might be some 5 to 10 minute YouTube videos that are educational, explaining frequently asked questions, what to look for. There are some drawings, and there are some videos of the actual procedure for those that are interested in it. There are links to papers that we've written on the subject matter. And so all of the information is sort of in one location, so that for a family that's interested in learning about it, it's all in one place. They can click on different things. They're not doing random things on Google, wondering whether they're going to find something, but not even knowing whether something is now out there or not. And I find it very helpful for patients and families. And my secretary now, oftentimes this is the avenue. This is the first interface with the family is, Dr. Dearani, there is a Facebook page for this anomaly, Epstein's anomaly, or hypertrophic cardiomyopathy, or robotic heart surgery, whatever. And before you talk to him, it would actually be helpful for you to just, spend a little time on that, learn a little bit about it, become familiar with the terminology, and then when you talk to him on the phone, it will be much more constructive, and it will be much more educational, because you won't be hearing words for the first time, and it will be much more meaningful.
Absolutely.
And most of the public is on Facebook, so we have found it very, very. I mean, we're in the era of technology, and it's a very easy way to communicate and correspond. Once we get into specific patient-related things, it comes completely offline, and it gets into my office. There's nothing online that's done personally about a patient's medical condition. The social media Facebook thing is the introduction. It's the way to make the connection, and then once we get into the specifics of an individual patient, it gets taken offline.
I have one kind of last question for you, something I think is a great way to wrap it up. We've been talking about social media, and you've really made a positive impact on thousands of children and families' lives. Is there a specific episode or patient that really stuck out with you?
There is. It's related to the Epstein thing. There is a support group. There is an Epstein anomaly support group Facebook page. I'm not on that. I feel that many of the patients and people on it are people that I've cared for, and I don't want them to feel like there's an invasion of privacy. They should be able to say and do what they want, and I don't need to know about it. But it was now 2 years ago. I was seeing a patient in follow-up. It was a young adult, and I had operated on her a couple of years previous. I always get worried when one of my patients is coming back, thinking that maybe there's a problem. There's a valve leaking again, and we're going to need surgery. And I looked at her echo images, and everything looked really good. And I thought, geez, I wonder why she wants to see me. And so I called the cardiologist who was seeing her, and I said, I'm seeing so and so back, and he said it's more of a social visit. She had a gift for you, and I said, okay, great. So I thought, well, that'll be great, So no surgeries needed, and it's going to be more or less a social visit, just what a surgeon would like in a post-op follow-up visit,
Right,
a social
exactly.
visit, no medical problems. And so we talked a little bit about her surgery, and everything was going well, and there was really nothing for me to add except reassurance that she was doing well. And then she gave me this gift, and it was a Shutterfly book. And it was a book that was put together by my patients from the Epstein Anomaly Support Group page. And one of the moms, a mom who at the time lived in Phoenix, she has recently moved to the Pacific Northwest. I had operated on her child, and she was very active in the social, media world, and she's a nurse, so she's very intelligent, and she's really dialed into knowing the concerns of moms and dads and so on and so forth. Well, anyway, she somehow collected captions and words and pictures and photographs, and it was incredible. It's probably the single nicest gift I have ever gotten because of the personal touch that it had, and I was speechless. It was probably the only time I had a consultation where I had tears in my eyes. I didn't know what to say. I was totally speechless, and so it was a great gift. And we bought a few extra books for the nursing staff and my secretary. She had one for my secretary, who's been a sort of she's been a real link, between the patient community and me in terms of orchestrating a lot of these phone conversations and consultations and so on. And so it meant a lot, and it just shows again the power of social media and what it has the ability to do. I mean, the stories and the pictures and the photographs. I mean, it was amazing. I mean, I have a copy of it on my desk, and I have one at home. And I mean, I look at it from time to time just to remind me, how good things are when I'm having a bad day. So.
Right. This sounds incredibly powerful. Thanks for sharing that. We're going to wrap up now. This has been wonderful having you here, Dr. Dearani.
Thank you for having me.
I feel like I've learned a lot as well today. So thank you, everyone, for joining us. Next month will be November 11th. We will be having Dr. Worrell on, and we'll be talking about pediatric epilepsy. So please join us. That will be at 1:30 Central Standard Time. Thanks, everyone, and have a great day.